Good evening, everyone. We thank the previous instruction course moderators to complete in time. Thank you very much. And without much ado, we'll start the last session for the day. This session is Current Understanding and Management Strategies in CSCR. Actually, we had planned this with external faculty. Unfortunately, he was unable to join us. Dr. T.P. Vignesh from Arvind Hospital, Madurai. He could not make it because of his prior commitments elsewhere. So we have reshuffled the talks amongst ourselves. With me here to my left is Dr. Sailesh. He is a consultant vitreoretinal surgeon in Thrissur Eye Vision Hospital. And to my right is Dr. Kiran Chandran, consultant at Giridhar Eye Institute. And myself, Dr. Jyoti Prakash, consultant vitreoretinal surgeon at Giridhar Eye Institute, Kochi. So the order of, we are trying to make it a bit more appealing by slightly altering the order of the talks. The first talk I will take over as the CSR and the pachychoroid spectrum, and then onwards we will gradually go as the sequence comes. The other one. Next one. Yes. So, good evening, everyone. I'll be talking about CSR and the pachychoroid spectrum disorders. How do I? So, pachychoroid, the term was coined way back in 2013 or 14 by Bailey Freund and his colleagues. It is defined as a condition which has a thick choroid with RPE disturbances with or without subretinal fluid, and it is not one disease per se, it's a continuum of multiple diseases which can present differentially. The evolution now encompasses focally or diffusely thickened kind of hallux layer with a secondary compression of the overlying choriocapillaries. The first component of a pachychoroid spectrum includes the pachychoroid pigment epitheliopathy. Here, if you look at it, you can see the photograph below, and the points which I have written here are just the descriptive markers which you can see in the OCT picture. I would like everybody to just focus on the OCT presentation. The yellow arrows which you see here are focal RPE epithelial abnormalities like focal or diffuse increase in the defects in the RPE. Along with that, underlying the RPE, you can see dilated choroidal vessels which are highlighted in the blue arrows, and typically here there is no subretinal fluid. This, if you see, this is how the fundus would look. To the untrained eye, probably this would look like a normal fundus, but if you look very carefully to the nasal part of this part of the fundus, you can see some mottling and RPE pigmentation changes. And the important investigative modality here to utilize is FAF, fundus autofluorescence. So when you do that, it very beautifully highlights the differential changes which are there at the level of the RPE. Another OCT feature which is found in the same set of disease, in addition to the pachy vessels, RPE changes and the other things, is an irregularity in the RPE which is highlighted as the yellow line here, and an elevation of the above overlying lines in the layers in the internal interdigitation zone. There may be also a presence of PED, serous PED, along with the dilated choroidal vessels, and mind you, here again we do not see any serous macular detachment. Fundus autofluorescence and ICGA are investigative modalities of choice which help to delineate the disease and differentiate it from the other sinister variants of the same. Another disease in this spectrum happens to be the pachychoroid neovasculopathy. Now, as the name neovasculopathy suggests, it is actually a set of new vessels which develop from the choroidal vasculature and come to lie below the RPE. On the fundus, you can very characteristically see a subretinal hemorrhage, RPE mottling, pigmentation changes, and the most striking feature which will differentiate it from a wet ARMD would be the absence of drusen. And when you do an OCT fundus autofluorescence, the presentation is no different from the one which we saw previously, and it is very difficult to identify it on an autofluorescence unless and until there is a large amount of hemorrhage which you see here. If the hemorrhage is very dense, you can see a masked large area of hypoautofluorescence. Doing an ICG also helps highlighting choroidal hyperpermeability in these areas. The whitish lesions which you see here are hyperfluorescences due to the choroidal hyperpermeability. The pachychoroidal neovascular features can have lesions below the RPE. That's a type 1 lesion. Subretinal fluid will be there here, which indicates the exudation. A shallow irregular PED or a DLS, as you call it, double layer sign, and infrequently there may be some element of cystoid macular edema. The other treatment modalities here, as we have seen already, ICG and autofluorescence are important, and one more important modality which happens to be non-invasive and gives a very good utility in following up these patients is OCTA, which can actually delineate the lesions very well and can be followed up based on that. This is how the lesion will appear. All modalities put together. This is the fundus picture. Here you actually cannot make out any fundus or any hemorrhage here. Other than the RPE mottling, you cannot make any difference whatsoever. Autofluorescence will actually only delineate the area of hyperautofluorescence surrounding an area of hypoautofluorescence. ICG will show an area of hyperfluorescence in the later phases, and OCT will show some element of serous macular detachment, irregularity of the RPE, and some fluid below it with a thickened choroid. The third variant is a PCV. Now PCV, I have not deliberately put any photographs because it's a separate topic in itself. It is just to iterate that it forms the same part of the continuum. We've had some patients which started off in one eye with CSR chronicity over a period of set of years, and 15 years down the line the same patient landed up with a focus of PCV in the same eye after a period of 15 years. So these form the part of the same continuum. Another characteristic feature which is seen in this, the fourth element which is seen here, is a peripapillary pachychoroid syndrome. It's called the PPS. It's typically has been defined as a present occurrence which is seen in the eyes of the contralateral eyes of patients with CSCR, and generally it is seen nasal to the macula with choroidal thickening near the optic disc. The features usually would include chronic choroidal venous hyperpermeability, pachyvessels, pigment epitheliopathy, and serous PED. More or less the symptoms are similar, but to differentiate between the two is just identifying the morphology and looking at the various kind of a pattern recognition. You see it 2 times, 3 times, the 4th time your brain will automatically feed you the diagnosis. And the last part in this is the focal choroidal excavation. This is a very common finding which occasionally all of us would have seen in OCT findings, and we usually don't register this we don't register it very aptly. But while looking at it in the literature, then we get to know that yes, this is what is called a focal choroidal excavation. Now it has a twofold implication. It can be a sequelae of a disease, and it can be the initial insult with which the disease develops. So it can be the cause as well as the effect. And this is of two types. It can be a confirming type and a non-confirming type. In the confirming type, the overlying retinal vessels actually course the entire curvature of the focal choroidal excavation. And in the non-confirming type, as you see here, the cavity dips down below and the layers are above in the upper part. There's a gap in between. So the pathogenesis is mainly said to be due to the venous overload, choroidal congestion, vascular remodeling, and RPE dysfunction, all of which lead to these different presentations. The importance is these differential diagnoses are the things which happen to differentiate these from the other sinister variant, that is the age-related macular degeneration, and the prognosis and the need for treatment, which lesions need to be treated, which lesions need to be observed, is important, and that is why differentiation amongst the different types is important. Thank you for your kind attention.
Shall we discuss at the end or?
Yeah, we can discuss at the end. Do we have any questions in the audience right now, or can we take it at the end? We'll take it at the end. Now I would like to invite Dr. Sailesh for his talk on CSR and its variants.
Good evening, all. Thanks to KSOS and Jyoti Prakash sir for giving me this opportunity. I'm Dr. Sailesh Kumar, and I'll be talking on the variants of CSCR. Central serous chorioretinopathy, as we all know, it's a chorioretinal disease in which there is idiopathic serous detachment of the retina associated with one or more areas of leakage from the choroid through a defect in the RPE outer blood retina barrier. So, but in case of CSCR, there is considerable variation in the clinical presentations of CSCR. The first or most common variant of CSCR is acute CSCR or typical or classic variant, in which there is acute localized detachment of the retina, which is clinically detectable on fundus examination and on OCT. The visual acuity loss will be only mild to moderate, with fundus fluorescent angiography showing one or few leaks, with limited focal or multifocal RPE alterations that may be limited to small pigment epithelial detachments. Acute CSCR classically affects middle-aged working male individuals, that is, it has a more of male predisposition, and this acute cases usually resolves within 3 to 4 months. So this is a fundus picture of an acute CSCR in which you can see a blister of fluid over the macula. And the corresponding OCT showing subretinal fluid at the macula with the dome-shaped elevation of the macula. So this is another case of acute CSCR in which you can see a point leakage with smokestack pattern on fundus fluorescent angiography, and this is the other eye, which was an asymptomatic eye that had carried a small CSCR which was away from the fovea. Here you can see a small RPE defect showing that there is a history of CSCR in this eye. There is a previous episode of CSCR. And the second variant is chronic CSCR. It was termed as decompensated RPE and diffuse retinal pigment epitheliopathy in the past, in which there is a widespread alteration of RPE pigmentation due to chronic accumulation of shallow subretinal fluid. Chronic CSCR is often arbitrarily defined when the subretinal fluid persists for periods longer than 6 months, and this accounts for up to 15% of CSCR cases. Interestingly, few patients with chronic CSCR have a history of acute CSCR, suggesting that they may represent distinct but overlapping entities. In chronic CSCR, the subretinal fluid and PEDs tend to be shallower than what you see in acute CSCR, and the patients also tend to be older, over 50 years of age, and more commonly they demonstrate bilateral involvement. In chronic CSCR, multifocal or diffuse atrophic changes in the RPE and neuroretina often develops, potentially as a result of the prolonged presence of SRF or underlying choroidal dysfunction directly affecting the RPE. And in these patients, the visual acuity loss will be more severe, moderate to severe, with symptoms will be permanent, and there will be decreased light sensitivity depending on the degree of photoreceptors outer segment damage. So this is a fundus autofluorescence of a chronic CSCR in which you can see widespread RPE alterations here. You can see the gravitational tracks in which there is this RP defects seen as hypoautofluorescent with surrounding hyperautofluorescent. This is fundus autofluorescence, FFA and ICG maze of a chronic CSCR. You can see these gravitational tracks, extensive RP defects with the fundus autofluorescence showing hypoautofluorescent gravitational tracks, and the corresponding angiography showing window defects, RP defects, and there is a leak here. So it's an active on chronic CSCR. There is a leak over here, and in ICG you can see the dilated choroidal vessels with increased permeability. And the OCT scan through this leak shows that there will be a dilated choroidal vessels just beneath the point of leak. The point of leak can be identified with this hyperreflectivity inside the subretinal fluid here. And then there is a third variant of CSCR, which is a very rare and less common variant, bullous variant of CSCR, which is associated with inferior bullous retinal detachment with shifting fluid. It presents as inferior bullous retinal detachment with shifting fluid, seen more frequently after organ transplantation. Usually presents with multiple PEDs hidden beneath a cloudy SRF. So when a PED evolves into an RP tear, an exudative RD may develop, becoming a clinical challenge. So this can be misdiagnosed as a rhegmatogenous retinal detachment or an exudative retinal detachment, secondary to other pathologies like Heradas. No significant differences between chronic CSCR and bullous variant in terms of age or sex. Various risk factors have been reported in bullous CSCR pathophysiology, including systemic corticosteroid therapy, organ transplantation, hemodialysis, pituitary adenoma, and pregnancy. This can appear as exudative RD, so people may start corticosteroids, which may even make the condition more worse. In bullous CSCR, there is no anterior segment inflammation signs and the vitreous is clear. The fundus examination reveals a yellow-white subretinal exudation at the posterior pole associated with exudative RD, usually inferior without retinal hemorrhages, acute chorioretinitis, retinal tear, or choroidal detachment. So this is a picture of bullous CSCR in which you can see the exudative RD inferiorly in this picture. And in this picture, you can see the bullous exudative RD inferior temporally and also superior temporally. Next is steroid-induced CSCR. This is not a separate entity, but some specific points about steroid-induced CSCR. Systemic corticosteroids have been associated with occurrences, prolongation, exacerbation, and recurrence of CSCR. This has less male predilection than idiopathic CSCR and has frequently a bilateral and atypical presentation. So when a female patient presents with CSCR, you should ask the history of any steroid usage. Exudative bullous detachment, subretinal fibrin and fibrosis are more commonly seen in corticosteroid-induced CSCR because it causes diffuse retinal pigment epitheliopathy. And CSCR and pregnancy, the risk of CSCR is higher in case of prior or current pregnancy, particularly during the third trimester, and it can resolve spontaneously after delivery, linking cortisol levels or pregnancy-associated hormonal variations to CSCR. Then this is a picture of chronic CSCR, but predominantly peripapillary. You can see the extensive RP atrophic areas peripapillary. This is another variant of chronic CSCR with predominant schisis, macular schisis. These two carry a very poor prognosis. And then there is this multifocal CSCR in which you get multiple focal lakes all over, as you see here. Multifocal CSCR is usually seen in renal patient and transplant patients. They may be associated with fibrin as well. So there is another fibrinous CSCR, can be seen in pregnancy and patients with long-term steroid intake. So this is fibrin CSCR. Here you can see a yellowish white deposit just temporal to the macula in this picture. So this is fibrin, and this fibrins, these subretinal deposits may represent fibrin clots originating from fibrinogen leaking through the RPE. This is another picture of fibrin CSCR in which you can see this hyperreflectivity in inside the subretinal fluid. And this is another presentation of CSCR, very rare presentation in which it was complicated by an RP rip. So this presented as a subretinal hemorrhage. You can see the boat-shaped hemorrhage inferior to the macula here. This was caused by an RP rip, and the FFA and ICG did not show any polyps. So RP rips can also happen in CSCR. So basically CSCR can be classified as either acute CSCR or chronic CSCR, and chronic CSCR may be complicated by choroidal neovascularization or posterior cystoidal degeneration. So this was a recent classification proposed by Dr. J. Shaplani group, in which they have tried to classify CSCR as simple and complex with regard to the total area of RP alteration. If it's less than 2 disc diameter, it is...
Sailesh, can you
yes,
wind up?
Yeah, it's done, sir. So that's it. So in case of CSCR, you'll have to rule out other causes of SR of mimicking CSCR, like dome-shaped maculopathy, uveal effusion syndrome, acquired vitelliform dystrophy, inflammation like posterior scleritis and VKH, optic disc pit maculopathy, CNV, and systemic disease. These may also present like CSCR. Thank you.
Thank you, Dr. Sailesh, for the nice exhaustive presentation on the different types of CSCR. And you have actually covered one of the most rarest forms also, the one which has a subretinal hemorrhage and a large massive rip that requires a separate discussion altogether, but nice coverage. We'll talk about it at the end. Now I invite Dr. Kiran for his talk on multimodal imaging in CSCR. Now, Dr. Kiran has an extensive experience with multimodal imaging, and he can be called a literal expert on that. Over to you, Dr. Kiran.
Thank you, Jyoti sir, for the introduction. I'll be talking on multimodal imaging in CSCR. So CSCR can be diagnosed clinically, and even non-invasive modalities, especially commonly used OCT, can be enough to diagnose a case of CSCR. But additional multimodal imaging using FFA and ICGA can assist in CSCR treatment modalities and provide insights into the choroidal changes also associated with the disease. So as I said, OCT is the most common imaging modality for evaluating as well as following up cases of CSCR. So when supplemented with enhanced depth imaging, it can even evaluate the minor details of the choroid and gives information on the subfoveal choroidal thickness. So as already mentioned, the CSCR is part of the pachychoroid spectrum entity. And by pachychoroid, there is the exact definition is still debatable, but the broadly accepted definition is between the range of 300 to 395 microns. In acute CSCR on OCT, you get this picture where there is subretinal fluid collection, and there's elongation of the photoreceptor outer segments, which you can see over here, and this happens to be due to the lack of phagocytosis by the RPE, that is dysfunctional RPE. So associated findings of CSCR can also happen in the form of small PED, like serous PED. And over here, what you see is like the sagging or the dipping of the posterior of the neurosensory retina. And there is a small RP rip exactly over here, and a fibrinous material covering it, and there's an appearance of a vacuole sign. And these are sites of fluid egress in CSCR. So you get, when you do an FFA, you get a leak at this corresponding to this region. Then subretinal hyperreflective material in CSCR was initially reported by Gas and colleagues, and is more prevalent in pregnant women and those with history of steroid intake. And the exact material or composition is still not clearly understood, but is likely to be due to proteinaceous materials mainly composed of fibrin. So this is a case of fibrin CSCR where you can see a subretinal lesion, yellowish lesion surrounded by subretinal fluid, and FAF shows hypoautofluorescence corresponding to the lesion due to masking of the background autofluorescence. On fundus fluorescent angiography, you get an ink blot pattern of leak, which is very obvious in the late frames. And on SD-OCT, a subretinal fluid is seen with subretinal hyperreflective material corresponding to that yellowish lesion clinically. And all these features give an idea that the patient has got an element of fibrinous component of CSCR. Chronic CSCR happens when there is persistence of subretinal fluid for more than around 6 months duration, and this leads to morphological changes in the retina. So the changes start from the outer nuclear layer, ellipsoid zone can be affected, And even when the disease progresses and when the disease reaches a state of chronicity, you get cystoid changes called as cystoid macular degeneration. Intraretinal and subretinal hyperreflected dots are again signs of chronicity. And flat irregular pigment epithelial detachment, as you can see in this diagram over here, involves elevation of the RP from the underlying Bruch's membrane. It indicates that there is definitely an element of macular neovascularization developing, and you need to follow up these patients very carefully. So OCT prognostic factors include hyperreflected dots. It can be either in the inner retina or even the subretinal layers. So the above figure shows hyperreflected dots in the inner retina as well as subretina and even overlying the RPE. And the bottom figure mainly confines to the photoreceptor plates and above the RPE. So the presence of these dots, as I mentioned, are indicators of poor visual acuity and chronicity. Cystoid macular degeneration, large cystoids can be seen. These are degenerative cystoids and associated poor visual outcomes. Outer retinal changes needs to be carefully analyzed because they again give an indication of the visual status in these patients. The disruption of the second hyperreflective band, that is ellipsoid zone, the overlying external limiting membrane, the outer nuclear layer thinning, they are all indicators of poor visual outcome, especially if they involve the fovea. On fluorescent angiography, you get multiple leak patterns. The most commonly observed ones are the ink blot followed by smokestack. And you also get pooling of the dye in areas of serous macular detachment, and it occurs due to collection of dye within the enclosed space. So here's an example of ink blot pattern where there is progressive and uniform expansion of this hypofluorescent spot from the early to the mid, and there's leak from that area from a central pinpoint. This is a smokestack pattern in which there is ascending hypofluorescence followed by lateral diffusion of the dye in a mushroom-like configuration towards the late phases. This is a minimal enlarging spot in which there is a small hyperfluorescent spot, but it sort of fades away in the late phases. There's no, it's very difficult to even say if there is an obvious CSCR leak in these patients. So chronic CSCR shows mottled areas of hyperfluorescence due to widespread window defects or RP atrophy. FFA can also detect the presence of macular neovascularization. ICGA can be categorized, changes can be categorized in early, mid, and late phase findings. In early phase, you get delayed filling of the choroid capillaries and choroidal arteries. In mid phase, focal choroidal hyperfluorescence can be seen, mainly due to choroidal vascular hyperpermeability. Dilated choroidal vessels can be also seen. And towards the late phases, you get the stipple hyperfluorescence spot, that is punctate lesions, mainly because of transient hyperpermeability of the choroidal vessels, which fades away towards the late phase. ICG also helps in identifying MNV that complicates CSCR, and it appears as ill-defined lesions with late staining plaques. Associated polypoidal choroidal vasculopathy can also be diagnosed since it's because overlap cases can occur with CSCR. The vortex veins can be identified very beautifully using the wide-angle systems. So this is a case which shows defects involving the retinal pigment epithelium at the macula. On fundus fluorescent angiography, you get an ink blot leak. ICGA demonstrates hyperfluorescent nodular lesions, which signifies the presence of polyps in this area. So you've got a coexistent polypoidal choroidal vasculopathy like picture with CSCR, and this is confirmed using an OCT scan where you get a typical notched PED corresponding to the polyp with adjoining subretinal fluid as well. ICG also helps in guiding treatment using photodynamic therapy, and PLACE trial which was done recently is an important guide for this. Fundus autofluorescence is an important marker of both photoreceptor and RPE function. Lipofuscin, which has got autofluorescence property, it accumulates within areas of dysfunctional RPE and due to incomplete phagocytosis of this photoreceptors. The two types of FAF imaging techniques, that is short wavelength and near infrared. Short wavelength originates from the lipofuscin present in the RPE, whereas near infrared gives information about the melanin from both the RPE and choroid. So different autofluorescent patterns are seen in acute CSCR. You get area of hypoautofluorescence in acute CSCR due to fluid collection, and areas of hypoautofluorescence can also be seen corresponding to areas of leakage on fundus fluorescent angiography. In cases where FFA is contraindicated, even you can use FAF as a tool for treating these patients with focal laser. In chronic CSCR, you get different patterns like diffuse hyperfluorescence in the early changes. More than 4 months changes, you can see as like a granular pattern of hypo and hyperautofluorescence, and in long-standing cases, you get diffuse hypoautofluorescence. So nice gravitational track can be seen on FAF in this patient, and corresponding window defects are seen on FFA, and the OCT shows widespread loss of outer retinal bands. OCT angiography in CSCR helps in picking up subtle networks which may be missed on FFA and ICGA. And the presence of flat irregular PED is an important indicator for presence of MNV. This case, you can see RP defects at the macula, subretinal fluid is present, and just below it, you can see a very subtle elevation of the RP and from the Brooks. FFA just demonstrates triple hyperfluorescence. ICA does not show much changes except for the dilated choroidal vessels. Octa is extremely sensitive in these cases because of beautiful networks in the sub-RPE level, indicative of type 1 CNVM in a case of CSCR. Again, over here, this is the last example which shows only subretinal fluid and hyperreflected dots initially. FFA is again very inconclusive. There is no network on Octa. 6 months after half fluence PDT, you get what appears as an RP elevation and shallow subretinal fluid. And after 3 loading doses of Eylea, which this patient received, the OCT sections are dry, but you get a network which is forming at sub-RPE level. And after a complete course of 6 Eylea injections over a 3-year follow-up, you can see how beautifully the network is increasing in overall size and extent, but there is no fluid again, but the PED's height is increasing. So we need to keep these patients on close follow-up to both educate them about the need for maintaining those follow-ups and also for that whether they need treatment should the disease activates. So thank you.
Excellent presentation, Dr. Kiran. I'd request you to stand over there and continue with your next talk on treatment modalities in CSCR.
So this is my second talk on treatment modalities for CSCR. So with new updates in its management, several treatment modalities have come up being tailored for CSCR patients. As you all know, acute CSCR, we usually observe the patients hoping that it will obviously spontaneously resolve. Should observation fail, the possible treatment modalities include focal laser, sub-threshold micropulse laser, photodynamic therapy, or even oral medications. So chronic CSCR is associated with persistent disruption in vision. Half-dose PDT is the single most effective treatment for CSCR, but unfortunately it's not available. The dye is not available in our country. Observation is usually recommended as a first-line treatment for acute CSCR. About 90 to 95% cases are typically self-limiting with spontaneous resolution of subretinal fluid. Interventions may be needed if the subretinal fluid is persisting for a duration of more than 3 to 4 months, if there is multiple recurrences, or if the patient wishes to have a slightly earlier recovery of vision. So this is a case of acute CSCR in which there is a clear subretinal fluid, OCT, otherwise does not show any changes, and after just 1 month of observation, the fluid is completely resolved, giving a dry section at the macula. Observation without additional treatment within the first 3 months might be the preferred approach in most centers. The gradual resolution of neurosensory detachment can be observed from monitoring the patient from time to time. Visual recovery can also be enhanced by counseling the patient on modifying the risk factors. For example, cut down on smoking if he's a smoker, reduce the stress levels if he's taking steroids, to discontinue the risk factor of using exogenous steroids, etc. Even doing light activities, yoga, meditation, etc. helps in sort of resolving these acute CSCR cases. So managing a case of chronic CSCR becomes problematic. You need to look for the risk factors. Age is a factor again. Perform FFA and ICGA to reach a conclusive diagnosis for presence of leak points. Extrafoveal leaks should be treated with focal laser. Subfoveal leaks need to treat with low fluence photodynamic therapy or micropulse. If there's absence of leak, you need to observe the patients, and you can also try a course of oral medications. If there's no response, perform an ICGA and go for a low fluence PDT or micropulse. So focal laser photocoagulation over here, low intensity, that's level 1 retinal tissue reaction, short exposure with 50 micron laser burns are the common exposure parameters. Thermal laser directly applied to focal sites of RP leakage, which are usually seen only on FFA. And mechanism of action of this laser is not completely understood, but is believed to seal the leakage sites to photocoagulate the cluster of diseased RP cells. It also activates the retinal pigment epithelial pump by redirecting the fluid back into the choriocapillaries. So this treatment is effective for both acute and chronic cases. So some of the acute cases cannot be treated by laser photocoagulation because the leak points are very close or even within the fovea. So laser can only be applied if the leakage point is located at least more than 400 micron from the foveal center. Photodynamic therapy involves utilizing a bisudin dye, that is vertiporphin, and it uses laser light of 89 nanometers. with fluence of around, this is a full fluence like 50, and half fluence is 25. And it's used to treat both acute and chronic CSCR cases, and also reduces the vascular hyperpermeability. So PDT works by stopping the abnormal leakages, allowing for absorption of SRF, and reduces the choroidal hyperpermeability. And during this process, free radicals are released when the vertipofin dye is activated to restore the damaged choroidal vessels and vessels the RPE. As I said, vertipofin can either be administered full or half dose. The most common complication seen following PDT treatment is secondary CNVM development. So in order to minimize the occurrence of these complications, new treatment modalities using 1/3 the conventional dose. The conventional dose is 6 milligram. Even 1/3 dose using 2 milligrams have been tried in various studies with good effects. So this is a table which shows various studies which have been done using the various different dosages as well as fluence of PDT. And in most of these studies, we see that using half dose PDT itself is enough to have a substantial reduction in subretinal fluid as well as good improvement in visual acuity. So subthreshold micropulse laser, it uses subthreshold energy in a burst of micropulse. It selectively targets the retinal pigment epithelium without leaving much residual damage to the retina. The duty cycle commonly employed is in the range of 5 to 10%. There are several wavelengths of laser which is used to target different cells in the retina, such as green, yellow, and infrared, as you know. So the subthreshold micropulse is relatively safe to apply close to the fovea, as it is poorly absorbed by the macular xanthophyll pigments. So here's a case example of a 56-year-old female who complained of diminution of vision of both eyes, who had a best corrected vision of 6/18 and 18. On fundus photography, you see an area of serous macular detachment both in the right as well as left eye. OCT of the right eye shows subretinal fluid, whereas the left eye shows subretinal fluid with a small CLS PED. On fundus fluorescent angiography in the right eye, you get extrafoveal, small point leak extrafoveally, and a very subtle leak. If at all, you can call it a leak, as seen just above the foveal avascular zone. In the left eye, you get a more obvious extrafoveal leak towards the late phases. So over here, this patient received focal laser multiple times, and every time the patient came with reduction and recurrences. So it recurred around 3 times. So this was the follow-up. At each visit, the patient had an FFA done. So this is a sequential follow-up over a course of almost 10 months, in which the initial subretinal fluid is reducing in subsequent visits, but new leak points are developing extrafoveally. So that's why you can see an extrafoveal subretinal fluid developing over here, although the foveal subretinal fluid is reducing. The patient is maintaining almost a stable vision of 6/18 and 10. This is a left eye. Again, the sequential follow-up shows reduction in subretinal fluid over a period of 10 months. So this is multifocal CSCR cases are a little difficult to manage. This is an ICG which gives area of hyperpermeability of the choroid, and also helps in directing photodynamic therapy guided treatments. So this patient underwent full dose, half fluence photodynamic therapy, and you can see how beautifully the subretinal fluid has resolved actually, and the patient attained a final vision of 6/12 N6 in the right eye, and left eye again 6/6 N6. You can barely say that the patient had an episode of CSCR in this eye. So anti-VEGF agents again have been tried in cases of CSCR complicated by neovascularization. I do not advise you to directly jump into an anti-VEGF agent when treating CSCR patients. Studies have obviously varied in what they infer from these by using these anti-VEGF agents. So this is one of the patients who I saw 3 months back. He's a patient from UAE. You can see an area of subretinal lesion at the macula. The FFA shows a leak exactly just at the fovea. On SDOCT, along with subretinal fluid, you can see a subretinal hyperreflective material, and along with the PED. So it looks like a fibrinous element of CSCR. The patient underwent micropulse laser because the leak was exactly almost touching the foveal avascular zone. As you can compare, the subretinal fluid is slightly reducing. Even the subretinal hyperreflective material is also reducing. But patients called me up and said the vision is not improved significantly. So I went ahead with the ranibizumab injection by calling him again for a follow-up. And after this, patient attained the vision of 6/6 parts from vision of 6/18. So you can see how well sometimes in these cases anti-VEGF injections work. The other pharmacodynamic therapies include topical NSAID agents like Nepalac, which we commonly give in these patients. hoping that it has some placebo effect. And carbonic anhydrase inhibitors such as dorzolamide also helps in improving the absorption of SRF. Oral medications have also been tried in the form of eplerenone, spironolactone, etc., about which Jyoti sir will be also talking about on the pharmacotherapy of CSCR. But again, without much of literature regarding these oral medications. Thank you.
Thanks, Dr. Kiran, for the two excellent
Thank you,
talks. And now Jyoti Prakash sir will conclude the session with the final talk of the session, pharmacotherapy in CSCR.
So I'll be taking on the last topic of the day. It's pharmacotherapy in central serous chorioretinopathy. Now, as controversial as this topic is, it has been taken up deliberately just for open discussion on the existence of these treatment modalities and the reality behind whether how effective they are and whether they should be used or not. Understanding CSCR, you know, the other demographics and all, everybody has talked extensively about it. The various the mechanisms through which the pharmacotherapeutic agents work are, firstly, according to the various animal studies, it was found out that the mineralocorticoid receptor were the main receptors at the RPE cells, which actually led to the presence of the leakage of fluid from those cells, and the antagonists of these receptors tend to have a positive effect on reducing the fluid in these patients and improving the visual acuity subsequently. Eplerenone and spironolactone have been used extensively. According to some studies, it is said that both eplerenone and spironolactone are equally efficacious in managing CSCR fluid. The mechanism is that it blocks the mineralocorticoid receptors primarily located in the choroid and potentially reducing the choroidal vascular leakage, dilatation as well as the leakage. The efficacy, if you look at it, there was initially it was only anecdotal reports from different centers and different clinicians, but then came in 2020 or 21 early part when the Vichy trial was published, and it outright categorically disregarded the use of eplerenone as a modality for treatment, and it said that, and verbatim I just quote, that they said it was as good as a placebo. Then came in the role of beta blockers in CSCR treatment. Now, there are several studies in which people have used, again, metipranolol, nadolol, propranolol for reducing CSCR. Now, the reason why these tend to work is in a small subset of patients, as we all know from the historic teaching, that these patients are the type A personalities who are known to be prone to anxiety, and probably the effect of beta blockers on reducing the element of anxiety, that is how probably it helps in relieving the symptoms. That and all we do not know, because there has been no proper randomized control trial on this because of the anecdotal nature of the usage of these agents. Another very surprising detail which came up in the last 1 decade or so has been H. pylori eradication therapy. There have been some reports again in which people have actually shown that H. pylori eradication therapy using a metronidazole, clarithromycin, or along with amoxicillin for a period of 10 to 14 days actually tends to produce some level of reduction in serous subretinal fluid, although it cannot be quantified. Another important treatment, now rifampicin as a treatment option. Now I cannot vouch for it, but yes, I have used personally both eplerenone and rifampicin. Rifampicin, not now, at least 10 years ago, I was very rapidly using rifampicin, but then the mechanism of action is very simple. It is one of the most potent stimulators of what is known as the cytochrome P450 enzyme, which is the most potent metabolizing enzyme in the liver for most pharmacokinetic changes through which multiple drugs go. And since it stimulates that, it actually causes a rapid resolution of the cortisol levels in the body, due to which they say the fluid accumulates. The doses which was advised was somewhere between 300 to 600 milligrams, but I deliberately made a point here to actually put it here just to caution everybody to use this, because in a country like India, where tuberculosis even today is a very important medical concern, and it is a second evolving epidemic following the presence of HIV, these drugs should not be used unless and until there is no other treatment option available, which actually is not the case. Other treatments are way more safer and effective, as Dr. Kiran had also highlighted in the past presentation. Rifampicin can be used but should never be on your first thought ever. Methotrexate, again, they say it is has been used. The mechanism, no idea how it works. It's said to be given at a dose of 7.5 milligrams weekly doses. It said in one study they showed around a 62% resolution, and the duration which was given for which was about 12 weeks. That is a huge amount of immunosuppression probably going around for a 3-month period. So other potential treatment options include aspirin, which has been there historically since the early 70s. It's been there, probably due to its effect on plasminogen activator inhibitory level activity. Carbonic anhydrase, as Dr. Kiran had already mentioned, mifepristone, which is a glucocorticoid and progesterone receptor antagonist, and melatonin. Some of the pharma companies, you would have also heard, some of the people tend to push a particular molecule or a tablet which actually has some element of melatonin in certain indications. Now, how much it works, how really do they affect the patient, it really is a point of contention. So as far as the evidence goes, the strongest evidence is for mineralocorticoid receptor antagonists. The other one for rifampicin and methotrexate, the rest are limited and only insufficient evidences. So they are only mentioned here to just apprise you with the things which were used, and these are in no way the suggested treatment options. Another study which was recently done at Narayan Netralaya by Ramesh Venkatesh, he did a real world practice pattern of eplerenone, and this is in light of the after the publication of the Vichy trial, which actually kind of stopped many people, including me, from using eplerenone as a treatment modality in chronic CSR. It is not a treatment modality which is used in acute ones, but chronic CSR was the area where it was used. So he had studied around 241 specialists, 122 from India and 119 internationally, and they found out that out of the 241 participants, it was 62% used eplerenone, and the remaining 38% people used PDT. Now, the only problem is in India as of now, the Visudyne is not available, so PDT is not possible. Following which, the only other options which are available with us, one is eplerenone, the other is micropulse laser, and for an extrafoveal leak, it is the standard laser. So the patterns which were found in this was that 58% of the respondents used primarily for chronic CSCR. 49%, about half of them, gave a dose of 50 milligrams of eplerenone. 92% used it for 0 to 3 months, and 57% of the people used it when other treatments had failed. So even although Vichy trial says that this drug does not work, if you don't have anything at all, something like you don't have access to PDT, you don't have access to micropulse laser, you have a patient who has a chronic CSR with an added on acute on chronic pattern with a subfoveal leak, what do? You cannot say, I will not treat the patient. If you do not have anything at all, if the patient has a good renal parameter and no other medical contraindication to the use of eplerenone and no cardiac condition, you have to probably use anything at all. This probably is the only salvage point which can be utilized in such a situation. The regional differences in eplerenone use, as is always the case, Indian retina specialists tend to use eplerenone more frequently as compared to the rest of the world, and because, as the point has been reiterated more over and again, that the PDT is not available right now, and they start usually at 25 milligrams OD, and graduate to 50 milligrams per day. And they somehow the satisfaction rate with eplerenone use were good, whereas on the other side, in the internationally, the rest of the world, they were not so. All the other parameters were exactly the opposite of what data was received from India. So the Vichy trial results said that eplerenone is not superior to placebo. Global impact is that 69% of non-Indian specialists reported practice changes. They stopped using eplerenone altogether. 44% of Indian specialists still use. These are the people who have actually answered in this questionnaire, and continued use is in a limited capacity, only in select patients. This is a presentation actually where Dr. T.P. Vignesh was kind enough to send me 2 cases of his in which he had used chronic CSR patients in which he had used eplerenone. Now this is here is a 52-year-old male. If you see, he has a history of defective vision in the 6 months, although the vision mentioned here is 6/9, but the patient had a significant problem in near work. So if you when the patient underwent FFA, you can see a characteristic subfoveal location of the leak, and since PDT is not available, he was given the option of eplerenone for a period of 1 to 2 months, and surprisingly, the patient was called. He had called exactly after 12 days. Within which you can see there is a difference in the fluid. The fluid is gone, and the vision is improved from 6/9 to 6/6. Although this may not be as dramatic, I do not say that it works as magically in all cases, but in this case, yes, definitely there was an improvement. Another case which you can see now, this unfortunately he could not send me the fundus photographs because he was traveling, so he sent me only the OCTs. Now this is a patient who has a defective vision for the past 2 years, with a baseline visual acuity of 6/9 and a serous macular detachment with some intraretinal fluid also. An irregularity of the RP can be seen here. The patient was put on eplerenone for a period of 2 to 3 months, and actually you can see in the second month itself, the vision, although remained the same, the fluid has totally disappeared, and which remain completely off till the next 6 months of follow-up. Thank you.
Thank you very much, Jyoti sir, for the nice presentation. And I thank both my seniors, Jyoti sir and Sailesh sir, for the wonderful presentations. So we come to the end of this session. The session is now open for discussion.